So, first couple slides today are excruciatingly boring to talk about. I don't have anything fun to tell you about fingernails and hair, but you need to learn the basic anatomy of it. A fingernail really, fingernails and hair are both epidermal derivatives. You can see that in their anatomy whenever you look close. We're not going to look close up at a fingernail, but we'll show you a cross-section of a hair. So there's a couple of terms that are used to refer to things about the nail that you should be aware of. This free edge of the nail is sometimes referred to as the hyponychium. So that's an anatomical, the most distal edge of this nail. The most proximal end of the nail is referred to as the root, and it is attached to the nail matrix from which the cells of the nail arise. And you can see that matrix extends along the bed of the nail. The cuticle is sometimes referred to as the eponychium, and you can see that labeled over here. It is the proximal continuation of the lateral nail folds on either side of the nail. And then the lunula, that word should make you think of moon, a little half-moon shaped discoloration, is sometimes used as a clinical marker for vascularization. You can see the lunula change colors quickly by pressing on the hyponychium just briefly and watching the lunula change colors as the vascularization returns. So hyponychium, eponychium, cuticle, nail matrix, lunula, these are common terms used to refer to fingernails. An epidermal derivative. This is the hair. Couple of views of hair here. The one thing I do want to point out to you that I mentioned before here, well, two things that I've mentioned before, is the presence of the melanocytes. So I mentioned to you during the last class period all the places where melanin is important for color, and I told you before we're done I'm going to show you a cross-section of hair, and you'll be able to see the melanocytes there that determine the color of the hair, and there they are right at the very near this hair papillae at the base of the bulb of the hair, or the root or the bulb of the hair here. You can see the melanocytes accumulated here. That's where they're located. So you can imagine the hair color is coming very similar to the way to skin color is produced. These melanocytes have finger-like projections into the epithelial cells of the hair shaft, and they deliver that melanin to help produce the color of the hair that we see. All right. Now, so you'll notice as you look at the hair in its cross-section here that the majority of the hair itself is epithelial. But there is also some connective tissue associated with the hair, and I'm not going to beat you up over, listing in order the cortex and the medulla and the internal and the external root sheaths. That's not important. I just want you to see the epithelial nature of the hair, the presence of the melanocytes, and here's the second thing that I mentioned to you before, the presence of these multi-unit erector pili muscles. So we'll see them a couple of times today. I've mentioned them once already. These guys are attached to the hair, and they are autonomically innervated. So I want to say some more about, I want to use them as a launching pad to talk some more about autonomics with you as we're going through the introduction to the nervous system. So, erector pili and hairs and nails. Snoozers. All right. Now, there are a couple of types of hair. Vellus hair and terminal. Some textbooks list as many as a half dozen different varieties. Some textbooks talk about the different structures that cause curly hair and hair that is straight hair, and the different distributions of the proteins that cause that, and under close inspection which ones are flat and which ones are round, and I read that stuff and oh man, this is just excruciating. So I'm just making you aware of it. I'm not going to ask you about vellus and terminal hair. You've seen them. You took anatomy and you've seen a fingernail. You've heard me say eponychium and hyponychium, and you know that this is an epithelial-derived structure, nails and hair. All right. Now, this is a histology section moving us toward the erector pili muscles, and I want you to see a couple of things here. The first thing that you will always see associated with the hair, so there's your hair follicle, there's your hair follicle. the thing that you will always see associated with these guys are these sebaceous glands. And I showed these to you before. The sebaceous gland is responsible for making this product called sebum that appears to be somehow involved in keeping, nourishing the hair, keeping the skin, having an oily feel to it. So I want you to see them once again in a histosection here associated with the erector pili muscle. And I want to use that to once again remind you about the differences in the way the nervous system communicates with different types of muscle. Remember, the erector pili muscles are multi-unit smooth muscles. And we think about these multi-unit smooth muscle fibers as being controlled by autonomics, but not the same way that the mass of smooth muscle is controlled in our body. So the autonomic nervous system communicates with smooth muscle cells, erector pili muscle cells, by way of these varicosities. There are not specific nerve endings per muscle cell. However, the innervation of the multi-unit smooth muscle is more extensive than the innervation that we see in the sheets of smooth muscle that we talked about before. Sheets of smooth muscle, like in the stomach and the esophagus, the rest of the digestive system, like the sheets of smooth muscle that we find in the urinary system. These sheets of smooth muscle have a different anatomy that explains how the nervous system controls them. So the varicosities that you see here controlling the multi-unit smooth muscle appear to be laced between the smooth muscle cell layers. That is, the chemicals of the autonomic nervous system, and you're going to learn two of them today, the chemicals of the autonomic nervous system that communicate, that stimulate, that cause these muscles to contract are found closer to the cells than you would find in the sheets of single unit smooth muscle. So can you guys see that in this anatomy? How the nervous system, the autonomic fibers, the varicosity system interlaces within the multi-unit smooth muscle, and then they just lie along the top of these sheets? Now, you know enough already to know that that's not a problem, because the sheets of smooth muscle cells, the single unit smooth muscle cells, are connected by way of gap junctions. And so if you release neurotransmitter onto this muscle cell and it contracts, whatever you do to that one, you're going to do to that one, and that one, and that one, and that one. So they tend to work in unity, similar to the way we talked about heart muscle contraction, these syncytium kind of ideas where all the muscle cells are working together. All right, so the erector pili muscle helped me bring that up again. Now let me remind you, before we do our general review of anatomy, of how the nervous system gets to places and the language of that, let's remember this also. If we're talking about cardiac muscle or smooth muscle, we think in terms of autonomic varicosities. And there are some variations in that, as you can see, with the multi-unit and single unit smooth muscle. If we're talking about skeletal muscle, we have a very different anatomical arrangement. Skeletal muscles are very precisely controlled. The ends of the axons appear to almost plug in to the muscle cell membranes. The sarcolemma has these indentions, the sarcolemma being the muscle cell membrane, these indentions where the ends of the motor neurons appear to be plugged in. So you don't have this sort of general distribution of neurotransmitter like you do in smooth muscle. You're going to release a neurotransmitter in one specific location, and that is called the neuromuscular junction, where the end of the motor neuron communicates with the sarcolemma. Now, even though it looks plugged in, please note here that the end of the motor neuron is not in contact with the sarcolemma. So in order for the nervous system to make your skeletal muscles contract, in order for that to go, you have got to release a chemical from the end of that motor neuron, and it has got to talk to the sarcolemma. So I want to use this, the varicosity and neuromuscular junction anatomy, to talk about the specifics of the nervous system, somatic and autonomics, in just a moment. So you've been introduced. I'm going to come back to that in just a second. So let's tidy up the rest of skin. There are 3 kinds of skin cancer: basal cell, squamous cell, and melanoma. Now you should see in the names, because you've learned some histology, you should see in the names of these some information about these cancers. If it is a basal cell carcinoma, where are the cells in the skin that are rapidly dividing, creating the cancerous mass? Where are they? Stratum corneum, stratum lucidum, stratum spinosum, stratum granulosum, stratum spinosum, stratum basale. Papillary dermis, reticular dermis. Where are these cells, the basal cell carcinomas? Well, they are in the basal layer of the epidermis. Now, does it surprise you from what you know about the cells of the epidermis that this is a possibility? What do you know about the cells of the stratum corneum in relation to the cells of the stratum basale? Where do the cells of the stratum corneum come from? Were they produced there? No. The mitotic cells are in the basal layer. They regenerate, and those cells push outward superficially. They push out superficially. And remember, every 30 days, you replace all of them. So basal cell carcinomas are there. This happens to be, interestingly enough, the least dangerous of the skin cancers. Just simple excision, removing them, and there's not normally an issue. The second most dangerous type are these, the squamous cell carcinomas, and they normally arise in the stratum spinosum. So squamous cell carcinoma, when you saw that name right there, squamous cell, you should have thought to yourself, that would be a cancer of the squamous epithelial cell. That's an epithelial cancer. This is also an epithelial cancer. A squamous cell carcinoma, an epithelial cancer. Would it be possible, from what you know about histology, to have a squamous cell carcinoma somewhere that is not skin? If, for example, you have gastric acid reflux disease, and you have a long-term problem where stomach acid is moved into the lower portions of the esophagus, the lining of the stomach, which is simple columnar epithelium, and the lining of the esophagus, which is stratified, non-keratinized stratified squamous, undergoes some changes. The acid that you are exposing the stratified squamous epithelial cells of the esophagus with is likely to damage those cells, and they will respond to that by overproducing. That is the most common way to produce esophageal cancers, with the acid from the stomach damaging the epithelial cells. So what kind of cancer would you call that? That is a squamous cell carcinoma. So most people think when they hear squamous cell carcinoma, this is skin cancer. But there are other epithelial cancers that we would call squamous cell carcinomas. But you know this because there are other places in the body that are lined with squamous epithelial cells. The third type is the most dangerous. And by most dangerous, I mean dramatically more dangerous than these two. The survival rates on a metastasized melanoma are very low. Some estimates are less than 10%, if that gets your attention. So melanomas are very resistant to treatment, and we're going to talk about that for just a minute because I want you to have some general rules about them. Melanomas, where are the melanocyte cell bodies? In a section of skin. Remember from last class period? The melanocyte cell bodies are also found in the basal layer of the epidermis. So they are an extremely dangerous cancer because of their proximity to the lymphatic tissue and the dermis. And the cells that are become cancerous, malignant, can spread very easily because of their position. Once a melanoma has broken through the basement membrane of the basal layer of the epidermis, survival rates are very low. So it's extremely dangerous kind of skin cancer. All right, so one at a time. Basal cell carcinomas of the stratum basale, they're slow growing, and they can be cured by surgical excision. 99% of the cases, not very dangerous. Squamous cell carcinomas come from the spinosum, and they're oftentimes seen on the scalp and ears and lower lip. They will grow rapidly, and they can metastasize if not removed. Now, this word should make you think two things. If a cancer is metastasizing, you should think two things. One, it is growing, and two, it is spreading. So by metastasizing, that's what we mean, growing and spreading cancers. Prognosis is normally good. Sometimes you have to treat these with some therapies. Squamous cell carcinoma is second most dangerous. The third type is extremely dangerous. They're highly metastatic, and they are resistant to chemotherapy, the melanocytes. Now here's how you can do a quick diagnosis of whether or not you should be concerned about some kind of growth on your skin. Students have asked me many times in years past, I have a freckle that I'm worried about, or I have a mole, more likely a mole on my skin, I'm worried about it. Because in anatomy they learned that those are actually local accumulations of melanin, high concentrations of melanocytes. Okay, so what are the characteristics that I should look for? So here they are, the ABCD rule. Is it asymmetrical? Okay, so most moles are not asymmetrical. So generally speaking, a mole that's a nice round mole, as long as it's not changing in size, you don't worry about it, even if it's a large mole. So asymmetry is not a good thing. Okay, well, freckles are asymmetrical a lot of times, aren't they? They're not always round. Okay, so here's a second characteristic. The border is irregular. And by irregular, I don't mean asymmetrical, right? By border, I mean the portion of the whatever you're looking at that extends superficially off the skin. Border irregularity, that is, it's not smooth. Okay, so what does that do for most freckles? That eliminates them, doesn't it? Because most freckles don't have indentations, they don't have irregularity. You can't feel the irregular nature of the mass. So it's asymmetrical and irregular. Third, color. So normally if the color is consistent, so most moles are this dark brown or almost black color, and you don't see streaks or variations in them. If you have a freckle or a mole or something on your skin that has more than one color, a streak of red in it, for example, that you can see, or a streak of light brown through the dark brown, then you should be more concerned about it. And if you put together that it's asymmetrical and it has an irregular border and it has streaks of yellow and brown in it, now you've got a problem. And then the final thing is the diameter is larger than the size of a pencil eraser. If you put these four together and you've got something on your skin like this, then you should have it checked immediately. The ABCD rule of melanomas. Okay, so these things are treated normally by cutting not only whatever the melanoma is off the skin, but also removing a large portion of the skin around the melanoma. And the section is normally a deep section in order to try to get all of it. But look, the chance of survival is very poor if the lesion is more than 4 millimeters thick. These are very dangerous skin cancers. All right, last piece of skin are the burns. There are variations in burns. I like for my students to learn the definitions of the first, second, and third degree, and then to be able to predict how much of the body, to be able to know how much of the body would be covered by one of these burns that would be dangerous or life-threatening. And then, as the last part, how would you very quickly predict that? And so I like to teach the students the rule of nines in predicting burns. So a first-degree burn is epidermal only, a little redness and swelling and pain maybe. Second-degree burn includes portions of the dermis. And oftentimes when you include the dermis in the burn, you will form blisters from the underlying lymphatic and vascular tissue that's in the dermis. You have these little pockets of fluid that will form there from the damaged dermal tissue. So most of us, I think, have had a second-degree burn at some point in our lives where we had little blisters on our skin. That can be dangerous, so we'll point that out here in just a moment. A third-degree burn covers the entire thickness of skin through the hypodermis and oftentimes even into the underlying superficial and deep fascia and even into the muscle occasionally. So third-degree burns, entire thickness. The burned area appears this grayish white or cherry red or sometimes black color. Initially, there's no pain because the ends of the sensory nerve endings are cauterized by the burn. However, they will repair, and as they do, the pain will come later. So let's talk about the distributions of these burns using the rule of nines. So this rule estimates the severity of burns, and we say that you have a critical burn on your body if a quarter of it is covered with second-degree burns. I think I would argue that there are young people who have critical burns because of their trips to the beach every year who don't even know. We certainly know that the rates of hospitalization over spring break in various beach communities increases dramatically because of these morons who don't know how to protect themselves from the sunshine. So that's not a big number, 25% of the body. How would we predict that? Just hang on. We say that it's critical if it's 10% for third-degree burns. And these guys, especially if it's on your hands or your feet or your face, very critical when you have third-degree burns in these critical areas. All right. Now here's how you predict it. This is the rule of nines. Very quickly predict how much of the body is covered with either a second or third-degree burn. We say that the head is 9%, so 4.5 here and 4.5 here. So obviously it's a critical burn if you have a third-degree burn on your face. But how much of the body mass is head? 9%. We do the same thing with the arms. The front and the back constitute a total of 9%, so 4.5 and 4.5%. So if you have a third-degree burn on one limb, so a person is in a fire situation where their arm has a third-degree burn on it, from the shoulder to the fingers, that's life-threatening. It's considered a critical burn. That would be 9%. 10% life-threatening, you're right at the border there. So you can very, very quickly see there that their whole arm is burned. They immediately have to have IV. They've got to get to a burn unit. They're life-threatening problem. 18% on the front, 18% on the back. So you can see if the thorax or the abdominal pelvic region had third-degree burns. You can also see here that the young person's laying out on the beach and they've got a third-degree burn on their chest for a male and their back. This is certainly critical. That would be well over the 25% rule for a critical burn that could potentially be life-threatening. And then the same thing on the legs, 9% on the front, 9% on the back, a total of 18% for each leg. That is the rule of nines. Very quickly, how much of the body is burned? 25% second, 10% third. Can you predict it? Can you look and say, I see this patient, I see the third-degree burn, this is where the burn is, this is the mass, is it critical or not? You know immediately if you can remember the rule of nines. All right? Okay, now